Hello, I'm Dr. Daniel Kelly, director and one of the four founders of Pacific Neuroscience Institute here in Santa Monica, California. And today I'm going to talk to you about the surgical management of Cushing's disease with endoscopic endonasal surgery. One of the first things I want to emphasize about the management of patients with Cushing's disease is that it's a team sport. And that goes from the diagnosis to the surgical treatment and to the postoperative management, working very closely and collaboratively with our colleagues in endocrinology, as well as otolaryngology, and in some cases, radiation oncology. This is a paper we published back in 2012 on the concept of pituitary centers of excellence. And in no disease more so than Cushing's is this team effort really critical to optimally manage our patients with Cushing's disease. We have a long track record in the management of patients with pituitary adenomas, and particularly Cushing's disease. And this is just a sampling of our many publications. Many of these touch on Cushing's disease, and here are some specific publications related to our Cushing's disease management, particularly the surgical management. So just to give a little background on Cushing's, it's a somewhat uncommon disease, but probably uncommonly diagnosed in many instances. There's a very strong female preponderance, with 70 to 85% of our patients with Cushing's disease being women. The mean age is generally middle age, 30 to 50 years, but we see occasionally in children and in older adults as well. Unmanaged or undiagnosed, there's a significant increase in mortality and morbidity related to cardiovascular complications and abnormal glucose metabolism with diabetes, poor wound healing, as well as some psychological issues as well in many patients. So a very debilitating disease from what is typically a very small tumor with the excess production of adrenocorticotropic hormone and subsequently cortisol. So how do we diagnose Cushing's disease? Well, it's really a biochemical diagnosis, and this is where we have to work very closely with our colleagues in endocrinology. So urinary free cortisols, at least 2 late night salivary cortisols, given that the diurnal rhythm in patients with Cushing's disease is usually off so that they can have high cortisols any time of the day. Then we will often do what are called dexamethasone suppression tests to see if the pituitary gland is responding appropriately to high steroid levels. And this is very helpful for distinguishing between what we call central Cushing's within the pituitary gland or ectopic Cushing's. We look at obviously the serum ACTH levels. And then in some patients, we will do a angiographic study called inferior petrosal sinus sampling with corticotropin releasing hormone stimulation, whereby we actually stimulate the pituitary gland and the pituitary adenoma, if present, to produce ACTH. And this is a way for distinguishing a pituitary source versus what we call an ectopic source, where the tumor may be outside of the pituitary gland. So this is very important in some cases for determining the location of ACTH-dependent Cushing's. And I would again emphasize Cushing's disease is really not a radiographic or imaging diagnosis, although in about 2/3 of patients, even slightly higher, they will have a well-defined pituitary adenoma seen on pituitary MRI, and that's certainly a part of the workup. But this biochemical workup is really essential to sorting out whether someone has biochemical Cushing's disease or ectopic Cushing's disease, or in fact does not have Cushing's disease. So what are our therapeutic options once we confirm the diagnosis? Well, the first line treatment is really endonasal pituitary adenoma removal. Second line therapies would be considered medical therapy with agents such as ketoconazole, pasireotide, mifepristone. Radiosurgery and radiotherapy or stereotactic delivery of radiation to the pituitary gland is effective, but is generally for patients who have failed prior surgery or medical therapy. And then bilateral adrenalectomy, taking out the adrenal glands, which is the source of the excess cortisol, is also very effective in making Cushing's disease go away, but does carry a risk of a syndrome called Nelson syndrome. So this is really the order of approach, with pituitary adenoma removal being the first line treatment. And we do that these days with an endoscopic approach using a surgical telescope. through the nasal cavity, working through both nostrils to selectively remove the adenoma and preserve the normal pituitary gland. The road to success in endoscopic pituitary surgery involves many steps. First of all, patient selection and preparation, so making certain in Cushing's disease that the patient actually has Cushing's disease. The experience of the surgical team and having the appropriate instrumentation is really critical, and a number of studies have demonstrated that experience matters. The nasal phase is simply working through the nostrils and into the sphenoid sinus, but a very important phase in terms of preserving the vasculature of the nasal cavity structures and preserving olfaction, or the sense of smell. And we use what are called rescue flaps to preserve olfaction and to preserve the blood vessels. And this is a very excellent approach for quality of life for patients and preserving their sense of smell after surgery. We then open the sphenoid bone, performing what's called a sphenoidotomy, so that we can work through both nostrils and have a large working cavity in the sphenoid sinus. The exposure of the sella is critical to make certain that it's wide enough to really expose the entirety of where the tumor might reside, but not too far to potentially injure the carotid arteries. And keep in mind that the carotid arteries bracket or sit on either side of the pituitary gland, and we always need to know where they are. And in many instances, the pituitary adenomas go right up to the carotid artery, so it's critical that we know where they are, and we do that with a Doppler probe to confirm localization. Then the tumor removal proceeds, and in some patients with Cushing's disease, we have to make multiple incisions in the gland to localize the tumor, to find it. In others, we see it on the preoperative MRI and go straight to it. So it really depends on the imaging as to how we remove the tumor, but we also want to preserve the gland. At the completion of removal, we have to make certain that there's not a spinal fluid leak, and if there is, we have to fix that or repair it, prevent it from continuing post-surgery. And we usually do that with an abdominal fat graft, some collagen sponge, and some other material that we place as we are closing up at the end of the procedure. And hopefully this leads to success. And what we want to see in a patient with Cushing's disease is a precipitous drop in their cortisol and ACTH levels, typically within 24 to 48 hours of surgery, confirming that they are in an early remission. This is the room setup that we use. Again, 2 surgeons, team surgery with my ENT colleague, Dr. Griffiths, and myself, or Dr. Barkandarian or Dr. Sivakumar, neurosurgical team, working here using 2 high-definition monitors to visualize the surgical action, and our hands are gathered around the nostril here. As you can see, Dr. Griffiths holding the endoscope and me working through both nostrils, usually with the endoscope in the right nostril and our instruments in each nostril. Again, a very working, ergonomically comfortable approach for doing these pituitary adenomas. The surgical timeline, typically the operation takes about 2.5 to 4 hours. After surgery, the patient goes to a regular room, not to an intensive care unit. We monitor serum cortisol levels beginning at about 8 hours after surgery, and then every 8 hours thereafter, looking for this drop in cortisol. And we want to document subnormal cortisol levels, particularly or ideally below 5, and the lower the better in terms of long-term remission. Most patients will feel somewhat symptomatic and feel lousy, what we call the crash, as they withdraw from cortisol after many years of having high cortisol levels. We will get, if we achieve that, we then do place the patient on hydrocortisone, and we will do an MRI in postoperative day 1 just to see how we're looking. And the patients are usually going home on day 1 or sometimes on day 2. We then follow up on post-op day 5 with a sodium check. At this point, patients are usually on hydrocortisone. They follow up with both neurosurgery and ENT within 7 to 10 days of surgery, and then close follow-up as well with the endocrinologist. In terms of activity, although many patients with Cushing's disease feel somewhat tired within the first few weeks after surgery, they're up and walking on postoperative day 1, but with no strenuous activity for the first week. Flying is okay after 7 to 10 days, driving after 2 weeks, and really anything goes, including exercising after 3 weeks. But again, in patients with Cushing's disease, this may take some time. for them to feel really where they can do adequate exercise. Just show you a few case examples here. This is a 32-year-old woman with a classic history of Cushing's disease, 3 years of progressive weight gain, fatigue, insomnia, poor concentration and mood swings, as well as irregular periods. You can see here she had very high biochemical confirmation of Cushing's and a well-defined pituitary adenoma. The video shows here the opening and the approach here. We can see the adenoma. Now we're using a 30-degree endoscope to remove the tumor and separate it from the normal pituitary gland here in progressive fashion, trying to work around this pseudocapsule so that we ensure a complete removal of the tumor. You can see that we made a little incision in the anterior pituitary gland here to reach the adenoma, and that's very well tolerated by the gland. And we're using, again, a progressive dissection technique to work around the tumor and separate it from the normal gland. Ultimately, we have achieved a almost complete pseudocapsular dissection, and then we start to remove the tumor. And as you can see, the tumors, once we break through the pseudocapsule, are very soft, and they tend to fall apart. And here it's a lot of looking and multiple sweeps and making sure that we get all the way to the back of the tumor. This is the interface with the posterior pituitary gland. And again, looking way up with the 30-degree and 45-degree endoscopes, we're getting the very last remnants of tumor at the interface with the posterior pituitary gland. We then irrigate with full-strength hydrogen peroxide, and here is a simple closure, given that there's no spinal fluid leak, just with collagen sponge, and then some tissue glue. The patient went on to do quite well with her ACTH levels falling to non-measurable levels and a cortisol level less than 1. And she went into remission and was on tapering hydrocortisone dose at last follow-up. Here's another example of a patient, a man with a 2-year history of hypertension, weight gain, and fatigue, decreased libido, and again, markedly abnormal biochemical data with high urinary free cortisol and low-dose dexamethasone suppression testing. You can see here we're making an initial incision based on this small area we see right here, and we find that the tumor is partly invading the dura here, and so we're working around doing a pseudocapsular dissection around the tumor above, but ultimately we're going to have to resect some of this dura that is infiltrated to achieve a remission. So again, a very up-close view, beautifully visualized with the endoscope, working in this space to try to remove the adenoma completely. And here you can see we've opened up the dura. Now we're actually going to remove some of this dura, which probably has adenoma infiltrating it. This is very helpful for achieving remission. We can see here again, no obvious tumor, but now we're going to cauterize this dura to try and kill any residual tumor. And we do everything we can here to minimize the chance of a recurrence and make sure that the patient goes into a sustained remission. You can see the normal pituitary gland here looks very good. So then we flood the field again with hydrogen peroxide, which helps kill residual tumor cells. This is just making sure there's no further bleeding. And that's the end of the procedure. A simple closure, again, no spinal fluid leak. This patient, his cortisol level went to less than 1 on postoperative day 1, and he's been in remission for over 5 years. And then here's another woman, 59 years old, with a negative pituitary MRI, and this is something that we see frequently in about a third of patients where the MRI does not show an adenoma, and we have to explore the gland. You can see here on this MRI, there's no obvious pituitary adenoma seen, but she did undergo inferior petrosal sinus sampling, and she did have a larger gradient on the right side compared to the left. So that suggests the tumor may be on the right side, but that is not very reliable. So here we are opening the dura very carefully to not disturb the anterior aspect of the gland to make certain that we can get a very clean view of the anterior part of the gland to see if the adenoma may be resting right on the surface. So this opening is done very carefully to protect the normal gland and to explore it. So you can see here, we're really not seeing anything obvious. And because of that, then we start with some incisions into the gland, little by little, looking for that pseudocapsular plane that will separate and demarcate the normal from the abnormal. And you can see here that actually in this first incision, we end up getting fairly lucky to find something that looks like tumor within this first incision, that pale white area right there. That's highly suspicious. And so we're going to expose that a little more and ultimately place a ring curette back there. And sure enough, this is the adenoma here coming out very nicely. It's not possible to do a complete pseudocapsular dissection here, but with the up-close angled endoscopes, we're getting a beautiful view and able to really empty this area out of the adenoma. And here, just taking one last look, really opening that space up and making sure that we didn't leave any obvious tumor behind. And she also went on to have a precipitous drop in her cortisol and her ACTH levels and has gone into remission here. And you can see that her pathology confirmed an ACTH secreting or staining pituitary adenoma. And this is her postoperative day 1, showing that little wedge removal that we did to completely remove this adenoma causing Cushing's disease. And then finally, we do see many patients who have recurrent Cushing's or never went into remission after prior surgery. That's almost 20% of our patient cohort at PNI. And so she was re-explored after 2 prior surgeries in 2015 and 2016. You can see that there's a lot of scar tissue here. These cases are somewhat challenging. This patient could also not get an MRI because of hearing aids that she had. And so we're opening up the right cavernous sinus based on her prior surgery and operative notes, and it appeared that it would most likely be that the tumor would be in the right cavernous sinus. And sure enough, when we did that very carefully, again, making certainly we knew where the carotid artery was, that we were able to remove this tumor. And it's just a short video here showing us being able to do that. And she went on to go into remission as well, has been in remission for over a year. So these operations tend to be very gratifying for the patient and for us. These, as you may know, patients with Cushing's disease really have a dramatic deterioration in their body image, their body habitus, with hypertension, often diabetes. So these before and after pictures are really things we like to see where people recover so nicely. And this sometimes may take 6 months to a year. We like the hydrocortisone requirement to go on for at least 9 to 12 months. The longer the better. That suggests we're going to have a sustained remission and have happy patients like this, as you can see here. Here's one other patient who had this happen shortly after a pregnancy, and after surgery, she went into remission, and then she got pregnant again here, and this is before Cushing's and after, and she's now in remission for approximately 5 years. So in summary, endonasal endoscopic surgery remains first-line therapy for patients with Cushing's disease. Really critical to establish the diagnosis with strict biochemical criteria prior to embarking on surgery. And with careful patient selection and a large surgical experience, the remission rate is anywhere from 70 to 90%. And you can typically determine remission early on in the clinical course within the first 24 to 48 hours after surgery just by measuring the cortisol levels and the ACTH levels. Other options include medical therapy, radiosurgery, and bilateral adrenalectomies in a minority of patients. And we really need to follow our Cushing's patients long term because they can have recurrences. And really, the optimal management requires this close collaboration between neurosurgeons and endocrinologists. So we are certainly happy to see patients at our Pacific Pituitary Disorders Center. For those with an uncertain diagnosis, unclear that they have Cushing's disease, newly diagnosed, if you'd like to get a second opinion, and finally, if you have recurrent or persistent Cushing's after prior surgery. Thank you very much for your attention.